The SpyGlass direct visualization system from Boston Scientific has been the most recent introduction for the performance of cholangioscopy or pancreatoscopy. The main purpose of performing a cholangioscopy and pancreatoscopy traditionally has been for optically guided biopsies of biliary strictures or for performing therapy like lithotripsy, intraductal lithotripsy of bile duct stones. Traditionally, over the years, we have been using the mother and the baby endoscope system, which has been of fiber optic technology. The mother and the baby cholangioscopy system has evolved over 3 or 4 generations. However, one of the main drawbacks of the mother baby cholangioscopy system is its fragility, its extremely high cost, and various other problems like only a two-way tip deflection because of a single wheel and a very tiny instrument channel through which it is difficult to pass therapeutic instruments. The SpyGlass direct visualization system is actually a catheter based system which is of a 10 French diameter, and as you can see here, this is how the SpyGlass system looks. This is the control handle, and this system can be mounted on the ERCP scope itself, and therefore single operator who is performing the ERCP can also use the SpyGlass system. Now, this being a catheter based system, it is extremely durable and it is less fragile, so therefore it becomes overall less expensive. The other main advantage of the SpyGlass direct visualization system is it has got 2 wheels. You can see that there is a small wheel and there is a big wheel with a locking mechanism. So therefore the SpyGlass can be maneuvered in 4 different angles or in various areas of the bile duct, or if you are to study the pancreatic duct. In addition, the SpyGlass has got 2 channels. The first channel is to pass the actual fiber optic probe. This is a thin fiber optic probe which can be passed in through this, and this is a disposable instrument, and therefore you can get a good quality picture with every SpyGlass examination. This channel is to pass in other instruments like the SpyBite biopsy forceps once you have identified the stricture or the lesion inside the bile duct or the pancreas, or you can pass in lithotripsy instruments like the laser fiber or the electrohydraulic fiber. If you were to see the SpyGlass tip, you can see that there are also 2 dedicated irrigation channels, and this is the port from which irrigation can be carried out. So therefore, while performing a cholangioscopy, there is no need to place a nasobiliary catheter independently for irrigation. So through the SpyGlass system itself, we can perform irrigation while doing diagnosis or therapy. This fiber optic probe which goes in through the sheath is attached to this system, and as you see here, this is the processor into which the fiber optic cable goes, and this is the light source. This, which is kept above, is the water irrigation pump, and this continuously supplies water at a particular rate which can be adjusted, which comes out through the irrigation channels of the SpyGlass. Because of the better maneuverability of the SpyGlass and because of its durability, today the SpyGlass cholangioscope or pancreatoscope has become the instrument of choice for performing major interventional therapy like intraductal lithotripsy of bile duct stones. And with this, virtually any stone located at any place inside the bile duct, irrespective of its size or whether it is impacted, can be completely pulverized, and then we can achieve a complete ductal clearance, usually in one sitting of ERCP. The SpyGlass visualization system does have some drawbacks because of its fiber optic system. Sometimes if the bile is turbid, or if there is blood, or if there is sludge, or if there are flakes, the vision can become obscure. However, with newer and future developments, there is a possibility that the SpyGlass can be converted into a digital spy with which this small limitation of the SPY will also be overcome, and then this will become the main instrument of choice for intraductal diagnosis or for therapy. I am now going to describe to you the technique of cholangioscopy guided extraction of difficult bile duct stones. Now, she is a middle-aged lady who has presented to us with multiple attacks of jaundice, fever and cholangitis, and she was diagnosed to have multiple stones in her bile duct. Her gallbladder has been removed 10 years back, and since 5 years she has been getting these type of episodes. Her ERCP was performed elsewhere, which showed a few small stones in the lower bile duct with some large stones in the mid and upper bile duct, and some of these small stones were extracted by doing a endoscopic biliary sphincterotomy. In this particular patient, now first we are going to start cannulating this already cut ampulla by means of this ultratome XL, through which now we have already preloaded a dream wire, and cannulation is done first, and then by bending the sphincterotome the guide wire is gently maneuvered, and as you see on the fluoroscopic picture, because of the stones which are impacted, there is a slight difficulty of the guide wire to pass through the mid bile duct. However, we follow the sphincterotome up, and then the guide wire is again negotiated, and you can see how the guide wire is now entered the upper bile duct. In fact, you can see that radio opaque impacted stone on the X-ray picture, which is seen just next to those clips which have been applied on the cystic duct. Once we have gone up, then we put contrast only to visualize the number of stones, their location, and what is going to be our technique of crushing them under SpyGlass vision. So, you see here that there are at least 2 stones which we can visualize in the mid and the lower bile duct, and these stones will need pulverization by means of the SPY. You can see that these stones are slightly disimpacted now as compared to before, because this patient had a stent inside. Now, it is important to remember that whenever we are using the SpyGlass, contrast medium can come in the way because it can blur the vision. So, therefore, what we will do now is to go above and irrigate the bile duct with normal saline, so as to take out the contrast from the bile duct, and that makes visualization with the SpyGlass a little bit better. And as the irrigation is being done, suction is maintained through the ERCP scope, and I keep on sucking all the contrast out and keep on monitoring this under the fluoroscopic guidance. You can see that the contrast is slowly getting diluted, and gently now this contrast is much lesser than what it was before. So, the next step now is to go inside with the SpyGlass. For performing a therapeutic intervention with the SpyGlass, we have to remember that we have to preload the accessories in the working channel of the SpyGlass. For example, we have to put in this laser fiber, and through the catheter based system, which is the SpyGlass system, we have to put in this fiber optic cable. So, this yellow fiber is the fiber optic cable which is passed from this channel, and from this channel, which is the working channel, we pass in the laser fiber or the electrohydraulic fiber. Now, once we have passed and preloaded both these instruments right till the tip of the SpyGlass, then we pass the SpyGlass inside through the working channel of the ERCP scope. It is not necessary to load the SpyGlass over a wire and then take out the wire and then load the therapeutic instrument like the laser fiber, because this may sometimes be impossible because of the acute curvature at the ampulla of Vater. So, after doing a large cut like this, we can pass in the SpyGlass directly without preloading it over a wire. Once the SpyGlass comes into view, you can see here, I am going to rotate the wheels of the SpyGlass, you see here, and once the wheels are fixed, with a movement of the big wheel of the ERCP scope, the SpyGlass is introduced into the orifice, and then I push the SpyGlass inside the bile duct. To give the SpyGlass a proper direction, the ERCP scope has to be pushed inside slightly so that the SpyGlass can be pushed in the axis of the bile duct. Now once we have entered inside the bile duct, we have to enlarge the picture of the spy and then irrigation is started. So the SpyGlass is now pushed inside, and as we are going in, we keep on doing fluoroscopy so that we can visualize the inside of the bile duct. And you can see now that as we go in, we can visualize the stone. There is some amount of sludge or flakes which are seen, and these can sometimes obscure the view. However, this view can be very well cleared by maintaining a proper irrigation. So I keep on pushing the SpyGlass inside until I go almost till the stone, keep on performing irrigation. Okay, maintain irrigation, and as irrigation is maintained, I keep on sucking through the biopsy channel of the ERCP scope. The advantage here is because of the 10 French diameter of the spy, there is sufficient space by the side of the spy scope by which you can suck the fluid which you have instilled inside the bile duct. And now once the stone is seen, the laser fiber is further pushed ahead. You can see until it touches the stone. Yes. Suction, irrigation please. Yes. See, the laser fiber is gently coming out. And we can maintain the position of the scope by pushing or pulling the ERCP scope. Now you can see that the stone is very well visualized, and as the fiber is now gently being introduced. Yes, yes. You can see, you can visualize that stone, and once the fiber reaches the stone, we apply the laser, and you can see that with this we can do an intraductal lithotripsy under vision. You can see that the stone is getting fragmented. Hold the scope. Okay. Okay, so we'll go deeper inside now. Check with the fluoroscopy. Check with an X-ray. Yes, now we are reaching the stone. Now we are on the stone, but there is a lot of pus flakes inside and sludge, because of which the field can be obscured. Yes. Okay, keep it at the center. And this is how under vision even impacted large stones can be completely fragmented. Because of the two wheels and the four-way deflection, the SpyGlass can be passed even in the intrahepatic tree, and even the so-called irremovable stones like those which can cause a Merizi syndrome or those which are located in the intrahepatic ducts can very well be pulverized by using the SpyGlass technique. You can see how the stone is getting fragmented, and as the stone is getting fragmented, we move the tip of the SpyGlass so as to completely cover the stone in all the possible Wait, let me suck the fluid. Okay, it's gone to the left. Make it straight. Hello? Okay. Center. Okay, let's see now. What we'll do is we'll take out the fragments which we have pulverized and then we'll go in again. Okay, now gently pulling it back. Maintaining irrigation. Okay, we pull it back because the stone is below. Yeah. Yes, that is the stone. You can see on the ERCP scope picture that already you can see stone fragments which have been pulverized are automatically flowing out through the irrigation fluid. As we keep on pulverizing these stones, it's a good idea to intermittently take out the spy, go in, clear the duct and then go in again and then pulverize more, so as to keep the field of vision clear. Sometimes we have to use a combination of various techniques like SpyGlass pulverization along with balloon sphincteroplasty and along with sometimes mechanical lithotripsy for very difficult stones, or if there is a stone to distal duct discrepancy in the diameter. Like in this particular patient, first let us now go in and assess as to how much stones are remaining, what is the status of that stone which we have pulverized, and then take a decision as to how we want to remove these fragments. You can see on the fluoroscopic picture now that almost all the stone is completely pulverized. There is hardly any well formed stone which is seen, and these are all small fragments which are now there in the bile duct. So what we will do now is slightly extend this cut, perform a little bit of a balloon sphincteroplasty, and then we will remove these fragments by means of a stone extraction balloon catheter. So the ultratome is now pulled out, then it is gently bent. Bend the wire. Right, halate. Okay, and after bending the wire, now I am going to extend the cut a little bit. Okay, so first the fragments from the lower bile duct are first extracted by inflating the balloon. You can see how these fragments are now extracted, and these are all the pulverized stones which could be achieved only because of the laser lithotripsy. Yes. Now yes, this looks like a completely clear duct. So we go up, there is one small stone there still, yeah, okay. So that is the final stone fragment, and now with this technique we can achieve a complete ductal clearance in one sitting of ERCP. Just to confirm that there are no more stones, we again repeat a cholangiography after putting the balloon in the intrahepatic tree and then putting contrast. So we put contrast, and you can see that the bile duct is now completely clear of all the stones. There are some air bubbles which are seen there. So we make one more sweep of the bile duct, and you can see that the bile duct is now completely cleared of all the impacted stones. If there is some bleeding from the sphincterotomy cut, it is a good idea to inject some diluted adrenaline at the end of the procedure. We usually use a normal sclerotherapy needle and use 1 in 20,000 diluted adrenaline. A check fluoroscopy now is showing you a proper air cholangiogram with no radio-opaque stone left inside the bile duct. And in a single sitting we can achieve a complete ductal clearance, even if the stones are big, even if they are impacted, or even if they are located high up in the intrahepatic tree. So right at the apex of the ampulla, we give a little bit of injection, only to make sure that there is no post-ERCP delayed bleeding. This view can show you all the fragmented stones which have been removed after a properly performed intraductal SpyGlass lithotripsy. Because of the better maneuverability of the SpyGlass and because of its durability, today the SpyGlass cholangioscope or pancreaticoscope has become the instrument of choice for performing major interventional therapy like intraductal lithotripsy of bile duct stones. And with this, virtually any stone located at any place inside the bile duct, irrespective of its size or whether it is impacted, can be completely pulverized, and then we can achieve a complete ductal clearance, usually in one sitting of ERCP.